right, let's go ahead and get started. I'm Dr. Bob Seiss, addiction psychiatrist at Frontier Psychiatry, and joined here today by other members of our 3D Echo Hub. Amber, would you please introduce yourself?
Sure. Amber Rogers with Mountain Pacific Quality Health.
Mary?
Mary Argonis from Mountain Pacific.
Right. And if everyone else could please type in their name and where they're connecting from, including the organization and their role. We'd really appreciate that. We have a little bit of a light crowd today, in part because we did the old fake out, scheduled initially for the 30th and then changed it, acknowledging that, hey, we want to start on the first Wednesday in July. We are continuing with continuing education. Please sign in using the link that Amber has provided in the chat box. And you will be getting 1 credit hour for completing this session. Brief disclosure statements. Doctors Eric Arzubi, Reza Hosseini Gomi, and myself are all owners and co-founders of Frontier Psychiatry. And Reza and Amber have the financial interests noted here. Announcements. Oh. Amber, do we have announcements?
Just a quick reminder that when we send out the meeting notice, the invite, that you actually usually have to go to your other section if you're using Outlook. It doesn't come to your focused email. So that's always kind of a struggle a little bit for all of us. And then I don't think I have anything else. I will put in the link again for everybody.
Thank you, appreciate it. And if someone, so I'm using a different setup, I can't see everyone's faces and I'm having a hard time accessing the chat. Amber, please prompt me if and when we get a question. I can do a full stop and switch over. And if someone will let me know when Dr. Malcolm Horn connects, that'd be wonderful.
I believe she's in.
Is she? Okay,
well, let me see. Let me double check. Yes. Oh, Frances? Is her first name Frances? No, it's Malcolm, right?
Malcolm, that looks like you. Audio's not working. Okay. Dr. Malcolm Horn connects with us from the Rimrock Foundation, where she leads therapy interventions. And we really appreciate her input in talking through psychosocial interventions and the various different therapies we use to treat substance use disorders. Is there anyone else who's connected from the hub that we have yet to introduce? All right, let's take it away. Today we're talking about Kratom. We'll look to understand the unique pharmacological properties of Kratom, talk about the epidemiology of Kratom use, at least what we understand regarding the epidemiology, and the pertinent legal context, and acknowledge current forms of treatment for Kratom use disorder. Start off with a case. Please meet MG. He's a 37-year-old gentleman who presents to your clinic. He's working part-time as an event management company, and he's completing an MBA degree online. He does have a past psychiatric history remarkable for long-standing depressive and anxiety symptoms, and he reports several failed past trials of selective serotonin reuptake inhibitors. He often feels depressed and anxious. He's using over 40 grams of Kratom daily and notes that on some weeks, he spends as much as $200 on this habit. He's currently off psychotropic medication, acknowledging he generally prefers natural substances. He however notes that he's having recurrent withdrawal symptoms when he goes without Kratom, and his anxiety is getting worse, noting that Kratom isn't enough to treat my anxiety and depression. I can't take the withdrawal. What do we do? So I will call on people, and I think nurse practitioner Megan Lehman probably has the least fair disadvantage. Megan, can I ask, what would you do? If you don't mind unmuting and letting us know. It's not mutually exclusive. There's several right answers here.
I'm not exactly sure. I would probably ask more about the anxiety and what he's taken before. What has worked maybe in the past? Has he tried any like SSRIs or?
So we noted those failed trials in the past, but I like how you're thinking. And one thing we always emphasize in treating patients is to make sure that the SSRI trials were adequate. In other words, did they last the requisite minimum 4 to 6 weeks? And was the dose adequate? So I like that you're emphasizing, hey, let's see if the history as reported by the patient is actually accurate. For those of us who haven't encountered Kratom, we may be wondering, hey, what's this mention of buprenorphine? That's for opioid use disorder. Well, sure enough, while the evidence doesn't support insisting on abstinence from Kratom, and that's across the board for treatment of various substance use disorders, nor does it indicate that there's anything in the way of DEA approved Kratom dispensaries. There's no such thing, I just made that up. There is emerging evidence that buprenorphine can be effectively used as medication-assisted treatment for Kratom abuse. Also, as we would treat any substance use disorder, motivational interviewing, really soliciting from the patient his or her level of motivation and trying to unearth a changed narrative is definitely favored by the evidence. Also, treating depression and anxiety with evidence-based pharmacological treatment and providing 12-step facilitation. Kratom is a botanical that's derived from tropical evergreen trees in the coffee family. It's native to Southeast Asia, specifically Thailand, Malaysia, and Papua New Guinea. It's traditionally used by the indigenous people in those areas as a stimulant to enhance stamina and reduce fatigue.
Dr. Seiss?
Yes.
I don't think you're showing your slides.
Did it come off? Okay, let me go back. Is it showing the presentation? Or is that off?
No, we just seeing just you.
Okay, let's go back. Sorry about that.
You're the star of the show, but.
This is got to be fixed right away. Excellent. Can everyone see the slide deck now?
Yeah.
Wonderful. So Kratom's derived from a tropical evergreen tree in the coffee family, and we just talked about how indigenous populations will use it for different purposes. This is in part due to the fact that the response people see, dose dependent. Small doses under 5 grams, Kratom acts as a stimulant. Larger doses above 5 grams, it acts as a sedative narcotic with analgesic effects. You can think of it as a partial mu opioid receptor agonist, similar in strength to buprenorphine, once you have a dose above 5 grams. The leaves of the Kratom plant can be chewed, made into a tea, dried and smoked. Think about these forms of use as oftentimes delivering a lot less insofar as the dose of Kratom in comparison to the processed forms, like the extracts, tablets, liquids, gums, resins, powders, and capsules that are so oftenly consumed here stateside. We've seen a dramatic increase in use of Kratom in the US. We don't have great epidemiologic data, which we'll discuss in a moment, but we can say that use is now in the millions of doses each year. Reviewing national poison data and also taking a look at the New York City office, the chief medical examiner, we can see rates of different adverse effects from overdoses of Kratom. A fair number of people see agitation at extremely high doses, especially in excess of 40 grams a day, tachycardia, drowsiness, confusion, seizures, hallucinations, and even coma. The toxicity is dose dependent. You would hope that, given there is this risk for adverse outcomes, and as we're about to see, dependence, that this substance would be legal. Well, until illegal in many markets. Well, until 2015, Kratom was legal to grow and purchase across the nation. It now is illegal in the states of Wisconsin, Indiana, Arkansas, and Alabama. Certain cities and counties have banned Kratom, including San Diego, Sarasota County, Jerseyville, sorry, that's a typo, Sarasota County, Florida, Jerseyville, Washington, D.C., and Denver, Colorado. The DEA has identified Kratom as a substance of concern, but failed in making it a scheduled substance. In 2016, the DEA did advance a notice of intent to temporarily schedule compounds within kratom, specifically the opioids metragenine and 7-hydroxymetragenine. Yet the American Kratom Association, which is a self-proclaimed advocacy group for kratom users in the US, campaigned for the DEA to avoid scheduling kratom and its compounds. They succeeded in doing so. By the end of 2016, the DEA withdrew its scheduling request. And our reality today, everywhere you see solid green, kratom is fully recreationally legal. You can buy it in head shops, purchase it online. So that's all the geographies, at least the states, where people are connecting from, be it Wyoming, Montana, Alaska, or Hawaii. We don't know a ton about the epidemiology of kratom use, given there's not formal monitoring. This is not a scheduled substance. We can say, based on CDC data, that calls to poison control centers for some of those adverse events we just mentioned have increased tenfold over the last 10 years. Based on data from Southeast Asia, where there's much more of a tradition of kratom use, we've seen that 55% of users in those populations end up becoming dependent on kratom. In the US, a community survey was completed in 2017 by Grundom and co-authors. They surveyed kratom users and found remarkably the majority were white men in their 30s and 40s, married, employed, insured, with some college and income over $35,000 a year, and duration of use was more than 1 year but less than 5 years. Self-identified reasons for using kratom included a majority using it to treat chronic pain. Think again to doses in excess of 5 grams a day of kratom have more of a narcotic effect, whereas doses below 5 grams, it's more stimulating. It would make sense that people would use it as an anxiolytic or as a stimulant to help with depression. And a minority identified actually using it to treat opioid misuse as an alternative to opioids. A significant minority of those surveyed did end up disclosing their use to their medical provider. There are documented instances of death from kratom. It is fairly rare insofar as it being the only substance identified in a death from overdose. Oftentimes, when we do see deaths associated with kratom, it's when people are mixing kratom with other agents, especially respiratory depressants. Think alcohol, benzodiazepines, barbiturates, opioids. We've seen mixed results from using reversal agents for opioids, specifically naloxone. We've not yet seen a clinical trial used in which naloxone was used to treat kratom overdose. The withdrawal from kratom is extremely similar to opioid withdrawal. It starts about 12 to 24 hours from last use, can last up to 4 days. Patients experience very strong cravings and they get into a hyperadrenergic state, very similar to opioid withdrawal, insofar as experiencing some degree of diaphoresis, a lot of discomfort. Clonidine can make a big difference here, as well as the other comfort meds on the COWS withdrawal protocol. And we can use opioid receptor agonists, methadone, but more common and safer, buprenorphine, a partial agonist. High risk of relapse, and the rate we're seeing almost parallels that of opioids, up to 89% at 3 months. The withdrawal intensity is correlated to the amount used as well as the duration and frequency of use. Again, very similar to opioids. While we don't have a consensus insofar as how to treat kratom use disorder, in part because it's a new phenomena, we do have results of a survey that was done in 2020 surveying physicians working in addiction treatment settings. This data was presented at the Providers Clinical Support System presentation on kratom use disorder. They surveyed 69 physicians, and you can see that while the vast majority, 83%, both the orange and gray combined, did encounter some sort of kratom use, it was a minority, just this 28% in gray here, that saw kratom use disorder in the absence of opioid use disorder, meaning the majority of instances of kratom use were either concomitant with opioid use or subsequent to opioid use. And so in this survey, they focused on kratom use disorder in isolation, so absent opioid use disorder, historic or concomitant. And they saw that the majority of these physicians experienced success in treating the kratom use disorder with buprenorphine. And this is corroborated in the literature. If you look to the reports of treatment of kratom use disorder, absent opioid use disorder, the majority discussed effective outcomes using buprenorphine. Remarkably, consistent with what we've seen for treatment of opioid use disorder, for kratom use disorder, higher doses of kratom used require higher doses of buprenorphine as a maintenance dose for successful abstinence. For patients using less than 20 grams a day of kratom, they often stabilize on relatively low doses of buprenorphine. And this is consistent with what I've seen. In fact, that gentleman we saw earlier on stabilized, I think it was, on just over 8 milligrams of buprenorphine a day. A lot of that information was from an actual case I saw. Whereas the really high doses of kratom, in excess of 40 grams a day, they'll oftentimes require high doses of buprenorphine, or at least moderate doses, 12 to 16 milligrams a day. To summarize, we looked at the unique pharmacological properties of kratom. It is a stimulant at low doses, especially once you get down to like 1 gram a day, sedative narcotic at higher doses, higher than 5 grams a day. We talked about the epidemiology of kratom use in the pertinent legal context. It's widely available in most of the US, and abuse is booming, in particular here in Montana. We're seeing a high rate of relapse, 89%. And that's almost as high as you would see in opioid use disorder without treatment. And we talked about how, to date, medication for opioid use disorder, in particular buprenorphine, appears to be most effective. We can't say definitively how it would compare to other forms of treatment. I certainly do need to acknowledge, though, that, and I want to highlight this, and I really wish, Malcolm, that you were able to tell us, maybe you can chat in what you think about this. So in this physician survey, they saw that some degree of psychotherapy, perhaps only supportive, did come in as favored by physicians. Of course, you know, we do need to recognize that oftentimes in addiction treatment settings, the physicians focus almost exclusively on the medication piece and may not know what all else is going on in the patient's care. And then I do see a comment going back. I realize this is probably older, from Malcolm. What if he was using other substances during the trials of SSRIs? Does that negate the trial? It could definitely complicate whether or not we want to call a given trial of a selective serotonin reuptake inhibitor an adequate trial. Certainly if somebody's using, say, 4 grams of kratom a day and then experiencing intermittent withdrawal symptoms, that can really complicate how well SSRI would address the patient's anxiety. Malcolm, are you seeing a lot of kratom at Rimrock?
Yeah, can everybody hear me?
Yes.
Oh, excellent. Sometimes my earbuds don't work on my laptop. So we see more kratom when people are trying to, like in IOP, intensive outpatient, or where they're not supposed to use their meth or whatever else, they use the kratom. We've had a lot of patients who are on probation get in trouble because it's legal. So they're like, oh, okay, I won't do my meth, but they do that. And then they get a positive drug screen and they get in trouble for their kratom. So we see it more so with people that are trying to stop other stuff. And so they use the kratom in lieu of whatever else they want to use, even if opiates or a stimulant are not their drug of choice, just because they want to mood alter with something. They'll use the kratom because they hear it's legal. So therefore it's perfectly fine and safe, is what we hear.
And that's really consistent with what I've seen in clinics, both in Billings and then more broadly across the state. People treat it as though it were benign. And oftentimes you see people using it to self-medicate for opioid use disorder. Not necessarily knowing that, hey, it can have equal potency to buprenorphine and people will end up with physiological dependence.
We've seen some folks too, similar to what I see with like the cannabis edibles, where they just think, oh, I'll just keep taking it and not realize that they're taking too much. And we've had some people that really, I would say, I don't know the grams that they were taking at the time, but I would say overdose ready. Like they are at the point where you've just had so much, and they are truly, I mean, they're like, how does this, why am I like this because of, later? Why did that happen when it's something that I just could go buy? It was legal. And I truly see that as a problem where people say it's legal, therefore it's perfectly safe. And they don't recognize that just because it's legal doesn't mean it's okay and safe.
So I have a question. Because it is mostly purchased legally, is there a problem with, how like marijuana is laced with fentanyl and heroin and all? I mean, is it cleaner than other drugs or not?
I think that's an appropriate question. I do not know of any sort of adequate oversight taking place on the part of the FDA or any other federal agency, acknowledging that kind of in the federal government context, the DEA moved to schedule the substance, failed to do so. I don't know if there was follow through. You got to think, although who knows, depending on the year, you got to think though the federal government agencies do communicate with one another to some extent. And I would think if the DEA were moving in to schedule a substance, the FDA might not be actively looking to ensure its quality. So probably similar to cannabis, and also given that this is something that varies by state, whether or not it's legal, you do see in many instances lack of any sort of quality assurance or sufficient oversight from a government, because most likely, and please don't quote me, I would defer to anyone who's read up more on this, I suspect there's nothing more than perhaps state oversight when it comes to approving a given dispensary's ability to sell Kratom. And when it comes to ensuring that the Kratom is high quality, has minimal toxins. Also would highlight, it certainly can be hepatotoxic in ways other substances are. Certainly, unlike buprenorphine, if you get to a high enough dose, you can see significant hepatotoxicity. And it can be cut with other substances. Sorry, that was probably a really roundabout way to answer your question.
In the chat box, Eileen notes that in an assisted living, she had an employee that was using Kratom and was getting it at a national food store. I wonder if you mean natural, but. Other kinds of questions from the group?
Sorry.
Oh, go ahead, Eileen.
I did mean natural food store, yeah. And his wife, who also worked in the facility, when he finally really snapped, walked off the job, and the whole thing kind of imploded, she said that there were lines out the door at this store for people coming to get this stuff. And she had never heard of it before either. And now he was really deep into it. So it's bad stuff.
And a lot of people approach Kratom as if it were a benign substance because of the legal context. And I think that's something we have to recognize, be it Kratom, cannabis. Many members of the public are going to look to the legal status of a substance to figure out whether or not it's safe. And in this case, it really is one of the scenarios where, hey, the consumer needs to be aware and certainly wary of the fact that this is a highly addictive substance.
Yeah, and I'm assuming that, in all of our usual screening tools, this isn't necessarily called out. And because it's legal, unless they're specifically asked if they use the substance, you're probably never going to know.
And it's not commonly discerned on a UTOX. You have to actually specify in the lab order set that you want to look for Kratom. So to your point, Amber, it oftentimes goes undetected. We saw that, albeit a significant number, it's still a minority of people based on that community survey tell their healthcare providers. So there's probably tons of relatively silent use, at least insofar as we're concerned in the medical community and the patients we treat. This goes unreported. Oftentimes you don't see people present for treatment until something happens. I treated one patient when I was on the consult service who was hospitalized following an automobile accident and had remarkable opioid analgesia needs insofar as the doses of prescription opioids the patient needed. And finally it surfaced that, hey, this patient was abusing Kratom, well over 40 grams a day. And we ultimately did a Suboxone induction and stabilized the patient with buprenorphine, which simply put is way safer, has a much better known half-life, and is controlled. And to that extent, we can use it as a central component in treatment and keep things safe. Certainly there are other options. I suppose just like we're seeing for opioid use disorder, naltrexone will have more prominence at some point. Part of the thing that we're dealing with is it's relatively new and it's hard to detox from and has about equal potency to buprenorphine. So the switch is not that difficult. In fact, you don't have to wait for people to wash out like you would with opioids because it's only a partial agonist.
Any thoughts about, what's with the high relapse, after education and treatment, any what keeps people successful in their recovery?
I go whenever, for any patient, whether it's Kratom or anything, what got them into treatment in the first place? And sounds bad, can I manipulate that? Like if they, because often when people first want treatment, things are bad. And then things get better and they're like, it's not so much of a big deal. And if I can remind them, hey, remember 2 months ago when you came in and et cetera, so it's kind of trying to remind them of how easily things could go back to when it wasn't very good. Because you do see the people who think, oh, it's, I can do stuff once in a while, the DUI, oh, it was only one DUI, so it's not that big of a deal. And so I think if I can remind them, and I try to keep track on every patient what brought them in the first place, so that if I need to remind them of that later, I can, because I think that that's important. Because and I think we all have waning motivation. I mean, how many people say, oh yeah, I'm gonna start that diet and I'm gonna go to the gym every day, and 2 months later we're like Krispy Kremes and the gym is stupid. So I think everybody has waning motivation. And I think that if we can remind patients, gently and respectfully, hey, remember how things were before, remember what got you here in the first place. I think sometimes that's the way we can help them continue their motivation.
Thank you.
Yeah.
Any other questions from the group?
So apologies about the failure to share the slide deck there at the beginning. Wanted to just quickly go back and look at the case and emphasize the answers I had highlighted. So looking at, it's expert opinion at this point. It's far from a consensus or evidence-based treatment. It is essentially the best we have based on information available and interviews from people who treat Kratom use disorder, using medication-assisted treatment, in particular buprenorphine, leveraging motivational interviewing, and proceeding to treat depression and anxiety with evidence-based pharmacological treatment, along with the 12-step facilitation. That really is the best we have to offer for treating Kratom use disorder. In this scenario, we acknowledge the patient has a lot at stake, is in distress in part due to withdrawal, and acknowledges that the anxiety and depression are also a big piece of what he needs help with and the reason he's presenting for treatment. We had a case. It looks like the case presenter had to cancel at the last moment due to a patient emergency. But we can look forward to that case for next session. It does involve a patient who's abusing Kratom.
The group is awfully quiet today.
I would be curious how many people on the group have had patients that have been using Kratom and what that experience would be like.
I like it.
They're still quiet.
I know we also have a lot of nurses on this echo session, and I'm just curious if any of you have specifically ever asked your patients about this drug. I wasn't even aware that it existed, so I'm rather naive, and this has been a great learning opportunity. So. Other questions people have?
I would simply add, when it comes to Kratom use, it is the sort of thing that if you ask about it, you may be surprised how often you encounter it in patients. And that likely has at least part to do with the fact that it's legal and not necessarily viewed as a problem. And people wouldn't think to mention it when you ask just broadly about drugs. I try and always ask about it when I'm meeting with a patient who's abused opioids. As we see, kind of going back to that community survey, in the majority of instances, we saw that it was associated with, in 55% of the cases, which was, the majority of the cases, these two sections combined, the orange and the gray, the majority of these instances, people were using Kratom either after abusing opioids or concomitant with opioid abuse.
Dr. Seiss?
Yes, Jennifer, can we see you?
Oh, yeah, I think so.
Excellent, there we go.
I actually had a really interesting case at one point. It actually came from an APS worker who had a patient who was they were using Kratom basically as a chemical restraint. So they had her locked into a room and was feeding her Kratom. And at the time I was running a MAP program for a community health center, and we ended up having to do an induction for her. She had problems with dementia. She had no idea what it was. She just was completely she was she was drugged basically, and so she was completely just hanging out in this room by herself, and they would just give her Kratom after Kratom after Kratom. And it took a long time, but we finally got her off of it, and now she is in a long-term care facility. There was some damage that was done to her brain from using so much Kratom, but it was very sad.
That's incredibly sad.
Mm-hmm.
It certainly highlights the fact that we don't know a ton about Kratom. And if you look to the adverse outcomes that have been reported, in particular to New York City Poison Control and Medical Examiner, you're seeing that there is over 10% incidence of confusion, altered mental status, and it would make sense that this thing is neurotoxic, especially if somebody's being forced to consume it on a daily basis. Do you know if the patient was treated with buprenorphine, any form of
She was.
medication for opioid use disorder? Okay,
Yeah.
makes sense.
Yeah. And we finally did get her out of the situation and into a safe place. They just didn't know the kids initially had put her in a facility. They didn't like the facility, so they pulled her out, but then didn't realize how much work she was going to be at home. And so gave her to a family friend, and for some reason, I don't know how the ex-husband got involved, but he moved back in with her, and they were using Kratom just to keep her quiet because they didn't know what to do with her.
Wow.
Yeah.
That's a really compelling case. That's good that she was able to eventually make it to an official rehab facility or long-term care.
Yeah, she had all kinds of health problems, that were unaddressed because she was basically blitzed out in this room all day, and she wasn't taking her medications, and her hygiene was terrible, and it was bad. It was really bad. But I was glad that we could help her. So.
Thanks for sharing that case.
Yeah.
Any other experiences with Kratom that people care to share?
Hi, can you hear me?
Yes.
Hi, it's Alyssa. Sorry, my bandwidth is low, so this whole thing has been a little bit in and out the entire time. But I have never heard of Kratom before, and I'm not sure if you addressed it in the beginning, but did you mention that it's something that can be prescribed or that was given to some people in populations?
Yeah, we talked about the traditional use in indigent populations as an analgesic, and in particular focused on how you see a different response based on the dose.
Okay.
At lower doses, think less than 5 grams, especially once you get down to 1 gram, it's more of a stimulant. When you exceed 5 grams, it acts more like a sedative analgesic.
Okay, thank you. Thank you for clarifying. I was just curious.
No, certainly.
Not heard of it, so.
Mary, may I ask, do you know if Kratom is being widely used throughout Hawaii? Has it come up in discussion?
No, I'm sorry, I don't know.
Okay. You certainly saw a lot of it at the Seattle VA Addiction Treatment Center. And sure enough, a lot of people started off on opioids, transition to Kratom, and attempt to self-medicate, not knowing what they're getting into. Great. Well, thanks everyone.
Just one more quick question for you. You mentioned that in Montana in particular that there's, rising use. Is that just compared to other states? I mean, is there a reason behind that? Is it just the amount that because it's legal and people aren't aware? I mean, are we doing any community awareness campaigns about the drug?
So I haven't seen any campaigns in the Montana market. I have seen it elsewhere in Washington. I think, a lot of people are entirely unaware of the deleterious effects of Kratom and what can happen with long-term use. It would be wonderful to see. It sounds like we got a younger member of the audience. It'd be meaningful to see it perhaps done alongside cannabis, as now we have these two substances of abuse, and purely looking at the adverse outcomes, Kratom's a lot more dangerous, given there is, at least in the extreme, potential for overdose, especially when you combine it with other agents. Whereas with cannabis, it's incredibly rare to see any sort of overdose. So I think there definitely is a compelling need for more information. And
I worked a lot with the state addictive and mental disorders division. And I think I'm going to bring that up to her about the person I work with most closely and see if there's any kind of public awareness campaign that can be started, because, you know, even if you're the adult of a teen or whatever, and you don't even know that this drug exists, you've never heard of it, you know, and you think they're drinking tea.
Yeah, no, I think you make a lot of great observations of the need to really emphasize this when it comes to public health campaigns.
I think we're going to see a lot of the kratom and the recreational cannabis where it's legal, it's safe, it's fine, and people just don't know. And so I think I love your idea of kind of a public awareness campaign, because I don't think people do know. They think it's fine, it's totally okay. So it's made from a plant, it's all natural, without recognizing that a lot of things are made from plants. Doesn't mean that's safe.
I think we'll end on the early side today.